Greetings. I think most everyone is seated, so I'll go ahead and get started. I was impressed with the timeliness of everything so far, so I'll do my best to help keep that along. I think we even got a little back on the first one, but ended on track, so we'll try and keep on that this afternoon. Well, the second panel will be continuing some of the themes from earlier this afternoon, but really focusing on the outreach and collaboration and the community engagement part. I'll keep my comments limited. You can read the biographies in the packet, but I do want to just briefly introduce our four speakers. Heather Hauk, who is out moving her car so that she doesn't get towed, will be moving further down the list, but she is the director at the Maryland Department of Health and Mental Hygiene, Infectious Disease, and Environmental Health Administration, which is a mouthful. And I had the privilege, actually, of working with Ms. Hauk when she worked in New Hampshire in a similar role with the state of New Hampshire. I'm from Boston, and we provide HOPA technical assistance around New England. So it was a pleasure to see her on the panel and to be able to work with her today. F.T. Burden is the president and CEO of the AIDS Interfaith Residential Services and Empire Homes of Maryland, where he's been in various capacities for 10 years or so, currently serving as the executive director of Empire Homes. They operate approximately 150 units with 102 currently in production, which is impressive and not an easy task, as you've already heard. Malcolm Cowley is both a HOPA client and resident, but also a board member of the National AIDS Housing Coalition, which you may or may not be familiar with, but it's really an advocacy group that you'll probably have a word or two to say about, but a very active organization in keeping AIDS housing and issues before Congress, especially. And then finally, Daniel Montoya, Deputy Executive Director of the National Minority AIDS Council, has more than 22 years of senior-level HIV/AIDS and public health experience, focusing on communications, public affairs, and project management. So I think that I've really been impressed with the high quality of the presentations and our presenters today, and so it's really my pleasure to be here. The only thing I think I'll say to frame the discussion is that just in noting and thinking about expanding community engagement and thinking about the collaboration, we really have a nice variety represented up here in our panel. We have, with Ms. Hauk, we have someone who represents a state agency that operates as a funder of AIDS services and public health resources in the state of Maryland, but is involved in planning and administrating those resources. We have a provider and a developer of housing and supportive services, and we have a consumer and an advocate related to AIDS housing and housing issues, and finally another advocate with the broader perspective from the National Minority AIDS Council. So from kind of funder to consumer to advocate and to provider, it's really a nice mix. So without any further ado, I guess with Heather back from her parking mission, she'll be able to go back. Would you prefer that we? No, that's fine. Okay. So Heather Hauk, thank you.
For those of you who haven't been outside recently, it's a little muggy out there. And when you have to sprint for 2 blocks to feed your meter and come back, you get a little warm. So I was asked to talk about a number of things in a very short amount of time. So I'm going to choose to focus my remarks on 2 main questions that I was asked to respond to, which I think are appropriate for the topic and appropriate for the audience. And those 2 things are, how does the state of Maryland engage community in our planning processes and in our resource allocation processes to address the needs of people living with HIV in our jurisdiction? And the second is, what has been Maryland's experience experience as part of the 12 Cities project or the ECHIP project, which is the Enhanced Comprehensive HIV Prevention Plan. So I'll spend my few minutes just talking about those topics, and then I'll certainly be happy to answer questions now that I have a meter and I can stay here a little bit longer. I can stay and answer questions afterwards. So in terms of how do we engage broad-based community involvement in the development of policy and programmatic responses, we in the state of Maryland have a number of different planning groups that we are either required to come to, required to have come to the table, or that we actually offer opportunities to come to the table. And those are entities such as the Community Planning Group, our Ryan White Part A Planning Council. You heard from Carolyn Massey. Carolyn Massey is one of our Planning Council representatives for the Baltimore Towson EMA. We also happen to have representation on the DC Planning Council because we have jurisdictions or counties that are part of the DC Planning Council as well. So we have those Planning Council representation. We have regional advisory committees. We divide our state into 5 regions, and those regional advisory committees are both prevention vendors, care vendors, as well as any other provider, consumer, or individual that wants to come to that table and talk to us about what the needs of the community are, what the needs of people living with HIV are, and how we should be allocating resources for prevention and care services to address those needs. We also have a number of different commissions. We have a Baltimore City HIV/AIDS Commission. We have an Anne Arundel County HIV/AIDS Commission. We have a Faith Advisory Board. We actually have a Faith Community Advisory Board that we sit with and help us talk about how we might engage the faith community in prevention and care initiatives in our state. We also have a couple of response teams because, as you heard Jeff allude to, we have a significant epidemic among our gay men and other men who have sex with men community. We actually have an MSM response team that sits at the table with us and talks about what we're doing in terms of responding to the epidemic among the gay men, men who have sex with men community. And we also have a similar response team for the transgender community because we have found that in our epidemic, transgender individuals are also disproportionately impacted by HIV. And so it's important to get community to the table to talk with us about where are people going, what activities, how does outreach need to happen, how does HIV testing need to happen in the state in order to really reach folks who may not otherwise walk into a healthcare setting because of a history of stigma, a history of discrimination, or other experiences that they may have. We also solicit community involvement and input by working with our Mobile Van Coalition. We try to get all of our mobile van entities to the table with us at the State Health Department to try to coordinate activities, especially because we try to use our surveillance data and our national HIV/AIDS behavioral surveillance data to really target those activities to zip codes and to communities that we know people need extra effort to reach with the Mobile Van Coalition. And then the last 2 ways that we engage community that I would mention are that we convene a number of stakeholder meetings. So if there's a topic of interest, so for example, a couple of years ago, we needed to change our HIV counseling and testing laws. And so we actually had a year-long process where we brought stakeholders to the table to advise and inform us on what those law changes needed to look like and what that needed to do going forward. We've done the same for looking at expedited partner therapy for sexually transmitted infections and a number of other topical issues where we feel it's important to bring stakeholders to us and inform us about what those policy changes need to be. And then last, we have a number of relationships with behavioral health entities. So we work with our partners, thank you. We work with our partners and our sister agencies in our behavioral health entities to talk to us about how we can integrate HIV testing and HIV prevention issues into substance abuse treatment facilities as well as mental health facilities as well. So that's just a snapshot of how we engage community. The second thing that I wanted to address based on the questions I was asked to respond to are what's our state's involvement in the 12 Cities Initiative and the ECHIP process. So as many of you may know, the Baltimore Towson MSA was part of the Enhanced Comprehensive HIV Prevention Plan, so which is the ECHIP entity. It's a CDC-funded project where we were asked to develop a plan that's a little bit different from how we traditionally plan for HIV prevention services, and to sort of reconfigure our HIV prevention portfolio based on that planning process. And so we sat with the 7 jurisdictions that are in the MSA, which includes Baltimore City, Baltimore County, and a number of other local health departments, engaged all of the community planning entities I just mentioned, which are part of the ECHIP process, ECHIP jurisdiction, and talked with them about what we needed to do to really address the epidemic more vigorously in the MSA. In addition, we also took the opportunity to use some of that funding to do a resource optimization modeling project. We worked with Johns Hopkins University, Dr. David Holtgrave. For those of you who are in the housing world or in the HIV world, you may be familiar with Dr. Holtgrave and his work both as a proponent of the relationship between HIV and housing. And he worked with us to really take a look at how we were spending the current dollars we have invested in the MSA and how we might reapportion those or redirect that funding in a way that is more cost effective and more effective in reducing new infections of HIV in the MSA. And as a result of that modeling, and some of you may have heard us present on that modeling, we actually started to make shifts in how we invest our current HIV prevention portfolio. We reworked to reinvest and increase investments in HIV counseling and testing, again, using our surveillance data and using what we know about the community needs to increase HIV testing, counseling, and referral in certain areas. We're using it to increase our investment in linkage to care and partner services, because, again, we know that when we work with individuals diagnosed with HIV, whether newly or folks who are retesting because they are engaging in a risk behavior, and offer partner services, almost 20% of those partners are found to be HIV positive and previously didn't know it or didn't test. So we know that's a highly effective intervention. And we know that the importance of linking somebody to care and, equally importantly, retaining them and maintaining them in care is really the key to driving down new transmissions in our jurisdiction. So we're increasing our investments in that area, in those areas, based on this resource optimization modeling project that we did. We are also as part of that, increasing our investments in working with people who are positive with evidence-based behavioral interventions to engage them, again, in behavioral change efforts that will reduce transmission and, again, equally importantly, encourage them to get into care and stay into care and on treatment. I think, as you've heard alluded to today during the first panel, folks who are on treatment and can have viral suppression are far less likely to transmit HIV to their sexual or needle-sharing partners, and so getting people on treatment and staying on treatment is part of the equation in terms of our effort in Maryland. I think there are still opportunities to be realized in the 12-city project, in the ECHIP project. We are still looking forward to the federal agencies that are part of the 12 cities project, working with us at the state and local level more intensively to give us better visibility on some data that would help us plan, give us better visibility on their investments that are not coming necessarily to us as a state health department or a local health department, but what else is funded in the community so that we can coordinate with those partners better. So we're looking for a little bit better coordination and collaboration around data, around funding, and ultimately any resource and making sure that any resource investments, whether it's from SAMHSA, whether it's from HUD, whether it's from CDC or HRSA, including the community health centers, are all coordinated and all are going to, again, optimize the resources that are being used in our jurisdiction. So I think we've made a lot of progress over the past few years in terms of working to address our epidemic in Maryland. I still think that there's work that we are committed to doing, and are hopeful that our federal partners are equally committed to working with us to coordinate and collaborate moving forward, both in housing, in traditional HIV prevention, and certainly in our behavioral health coordination efforts as well. So I will stop there now that I finally cooled down, and turn it over to Jonathan again, and we'll be happy to answer questions at the end. Thank you.
Good afternoon. I know it's getting late in the day, so I'm not going to belabor the point. I'm F.T. Burton, and I'm the president and CEO of AIDS Interfaith Residential Services and Empire Homes of Maryland. AIDS Interfaith Residential Services, which we have shortened and we affectionately call AIRS, was started by the Sisters of Mercy and the Central Maryland Ecumenical Council in the late 80s as the faith-based community's response to HIV at the time. And we essentially started with who were very, very sick individuals with a program called the Don Miller House, which is an assisted living facility that we operate and is still very much our flagship program. The organization's been around for about 22 years. We serve approximately 400 individuals and families who are infected, affected, and at risk of HIV and AIDS. We operate with a $3 million annual operating budget and have a staff of about 45 that provide supportive services, case management, and linkages to a number of other services. Essentially, between 1988 and about 2000, the organization's focus was about dealing with people who were dying with HIV and AIDS. And then from about 2001 to current day, the focus became about people who were living with HIV and AIDS. And so a big part of our focus was about self-sufficiency and what's required to do that. Things like workforce development and continuing education. So once the housing and everything was in place, it was important to get people kind of thinking about what's the next step now that, you know, it was that period of time where medications were advancing and that people were living longer and that folks could start thinking about a life after a diagnosis. So we specialize in serving special populations. Particularly, we work with Hispanic populations, with ex-offenders, and now, most recently, we've been really focusing on youth. We've gotten quite a bit of federal funding. In fact, the special populations that we are working with are HOPWA-funded SPINS projects, special projects of national significance, that have ultimately become permanent projects beyond the demonstration period. Around 2005, AIRS was doing, you know, as a housing organization, the case managers were also kind of acting as housing counselors, and we recognized that that really wasn't the most effective way to ensure that our clients stayed housed, which was really, you know, our preliminary goal. And so at that time, I was the deputy director, and I was in graduate school, and I was looking for a project, and I liked real estate, and I thought, well, why don't we look at, you know, creating an entity that specifically focuses on property development and management, specifically because it requires a certain skill set for the development and management. The board needed to have a certain type of background and so forth, and it was very different than the case management. We were also saying that that was also a more effective way of dealing with the clients because it was very difficult for case managers to be an advocate for a client on one hand and then say, I got to have your rent on the other. So the EHM side was very happy to say, I got to have your rent. Okay? And so EHM was really created as a social enterprise, while AIRS does a lot of requests of federal funding and funding from private sources. EHM is almost completely covered through property management fees, development fees, and the like. So again, it was created so that it would be a self-sustaining organization. It also has about a $3 million annual operating budget and about 15 staff, mostly related to property management and have that property management expertise. So they deal with intake and determining eligibility and rent collection and property management and leasing coordination. Malcolm's on my staff. So we deal with everything related to housing. One of the things that is unique about the way that we do our property management is that we do what we call case management, sensitive property management. All of our property managers, they have all the HQS certifications and all those typical things, but they also have an understanding of the special needs and circumstances that our clients come from that a typical property manager does not necessarily. So what it's done for us is helped us to create a healthy tension between property and case management so that we are both advocating for the benefit of the resident. But more importantly, it's created a great sense of communication between our property team and our case management team that ultimately helps to keep the person housed for a longer period of time. We do more frequent inspections than a regular property manager. So if you lease an apartment, you know that maybe your landlord might look once a year. Well, we do quarterly inspections. And during those inspections, not only are we looking at the facilities, but we're looking at, does the client have all the things they need? Is there food in the refrigerator? Are there things that are not there or that are signs that this person may be falling off track? And so those things are communicated to the case manager, for example, and is the way that we are able to be proactive and help the client stay housed longer. The housing model that we use is a scattered site model. It is units scattered throughout Baltimore City and County. We've done this because although it is more difficult and expensive to manage from a property management standpoint, it is a way to give our residents the most choice in where they want to live. Particularly in Baltimore, we've got clients that don't want to live in certain parts of the city because they've had histories of using or so forth in that area, and they don't want to be back there. And so we're happy to put them in a place, again, where they're going to be more successful. Our tenants pay 30% of their income, and they, really we're looking for people when they're coming in that are able to live independently. Self-sufficiency, as I said, is the goal of what we're looking to do. So workforce development, continuing education, connecting to those things is the way we move forward. Our operating subsidies are like everyone else's. We use HOPWA, Shelter Plus Care, SHP, TLP, Section 8, you name it. We use it to operate the properties and subsidize the rents for the residents that we serve. Our capital dollars, again, are like what you heard earlier, HUD 811. A number of our projects are HUD 811 projects. We've used HOPWA capital, home money, low-income housing tax credit, CDBG, and NSP as a way to develop the properties. So essentially, EHM's role is to respond to the programmatic needs of what programs need in the form of housing. And so if you look on your table, there's a brochure of one of our new projects, and this is an example of how we respond to the needs of what program says we need. So in keeping with our history and work in HIV, one of the things that we saw was a leading contributor to the high numbers of infection for individuals in Baltimore City was that there were a lot of young people. For us, we're focusing on ages 18 to 24 because that's when we can legally house them. And I think you heard in some of the data on the earlier panel about how that population is still disproportionately impacted, that the numbers are way too high. So we created an innovative project called Restoration Gardens, and you can read through it and it'll tell you who all of the partners and so forth are, that focuses on housing homeless and unstably housed young people ages 18 to 24. It's the only project of its kind in the state of Maryland. Took about $6 million to do. Was really done by the grace of God because it started off as a tax credit project when the market was going south and ended up as a neighborhood stabilization project and good old stimulus dollars. Thank you, President Obama. But we were able to create a unique project that otherwise would not have existed and is now serving as a model. We're being contacted from around the country from individuals that want to know how we do it. even when we started this 5 years ago was right at the time when EHM was starting. And so I think Martise maybe even spoke about, we didn't have the capacity to do a project that was as complex as this. And so what we needed to do was seek a partner, even though we were a developer. So we needed to have somebody that had the understanding of all of the intricate financing tools that were needed to do it, and also had the financial capacity so that our biggest funders would feel comfortable that we were in good company and that we would be able to get the job done. It was the best thing that we did. It was an excellent partnership. They were also a nonprofit developer. They shared our vision, and we still are very much the lead. We are the owners and operators of the project. So it's a project that we're very proud of. It is a complete example of collaboration. There were lots of this. Not only did this meet needs for heirs, but it met needs of what's called the Baltimore Homeless Youth Initiative, which is made up of like 20 youth organizations that all recognize that housing or lack of housing was a barrier to them having successful clients, GED programs, workforce development programs. You can't focus on anything if you have to worry about where you're going to lay your head. So we believe that housing is the first and foremost thing, and so we're very happy to be engaged in it. In terms of other community engagement activities, we do lots of projects with the state. We're doing something now called Partnership for Life that enables us to do more outreach. We're a housing organization. Outreach wasn't really what we did, but now we found that we have to do it because people think it's not a crisis anymore, unfortunately. And so we've had to build that in as a part of the work that we do in terms of communicating to folks that it's not over, folks. You know, we still need the attention and focus locally on the issues and the fact that we are disproportionately impacted, and that, you know, that there's still work to be done. And so we work with our local universities and other aid service organizations to do a number of large-scale outreach activities and testing. One of our really cool things that we do with our youth is that we have what are called service navigators. These are young people that operate with cell phones and laptops, and they're very mobile, and they're meeting young people where they are. In fact, I think at the Enoch Pratt Library, which is our largest library, they think that one of our navigators has an office there. But that's where a lot of homeless young people come, and so he's able to connect with them. He's able to lead them to our Youth Resource Center, which is a part of this continuum of youth services that we provide. And when they come in, they're looking for housing, but that's our opportunity to help them understand what their status is and to connect them to other types of services that they need. And because they want housing, they continue to come back, and that gives us the opportunity to continue to work with them as it relates to their status and anything else. And so we've been able to bring, you know, to create things out of necessity to meet the needs, but we've done it very strategically with, you know, very well thought out, we think, ways of putting it together to meet, you know, a need that wasn't otherwise being met. So again, like Heather, I'll be open for questions after the presentations.
Good evening. I'm going to try to keep this short and as sweet as possible. They asked me some questions, so I'm just going to answer the questions they asked me. First one they asked me was, how has housing changed your life? Two things you need to know. One, the blizzard of 1996. And the other one is the prodigal son. And I'll tie them both together in just a minute. But anyway, the blizzard of 1996, I was in an abandoned car. I had no idea that the blizzard was coming. And when I went to bed, or when I laid down in that car, which was my bed, I saw the ground. And when I woke up, I couldn't open the door because it had snowed that much. And I had on tennis shoes. The prodigal son, if you know the story, you remember that in the end, when he was with the pigs, and he was, you know, working with the pigs, he suddenly had what I call the aha moment. And he said, I'm going back to my father's house. when I woke up with that snow, I had that aha moment. You know, and we all have them. I mean, if you don't, you're not living. Because you always have these times in life where you say, how in the world did I get here? And that was the question I had to ask myself. How in the world did I get there? Well, in June of 96, I finally got housing. I got Hopper housing, and it changed everything. For one, being HIV positive and not being able to take your medicine. In 96, in the early 90s, when the medicines first came out, one of the things that you had to do was, it was 3 medicines. One you took once a day, one you took twice a day, one you took 3 times a day. Now try to do that and be homeless. That's not going to work. So I got healthier because I got pneumonia from being in that blizzard, by the way. So the other question was, would I still be alive if I hadn't got housing? And the answer would be no. I wouldn't be alive. It's hard being homeless by itself, but being homeless and having a compromised immune system is not going to work. And what types of stigma or discrimination have you personally encountered? I remember when I first told my daughter's mother that I was HIV positive. And it's funny now. So, but it wasn't too funny then, but it's funny now. But she walked around the house, she had the rubber gloves on, and she had bleach in one hand and disinfectant in the other hand. And every time I would go use the bathroom, she would rush in the bathroom and wipe everything down that I used, and she had this plate, and this was my plate, and she put it up here on the shelf, and, you know, and one day I got tired. So what I did was I would go in the bathroom, and I would turn the water on, I would turn the water off, and I would come out, and she would run right in the bathroom and start cleaning everything. You know, and then I would do the same thing again, and we played this game the whole day. Seriously, this went on all day. And finally, but what it did do, it sparked a conversation. And that was the thing that changed her opinion, because, you know, a lot of people, discrimination is just plain ignorance. People just don't know. And it says, what other examples or stigma of discrimination are you aware of that others suffered? I'm also on a board of directors for quality of life. And quality of life is a retreat for people who are HIV positive. Not only am I on the board of director, I am a director for one of the retreats. And so people call me and say, "Are you still got room on the retreat? Can I come to the retreat?" and all that. But one that sticks in my mind more than anything else was this guy called me from Charlotte, West Virginia. And he said, "Mr. Coley, I don't care how much it costs, please have a spot for me. Because I can't talk to anybody down here. These people down here don't understand. I can't even go to the doctor and tell my doctor that I'm positive because they just don't get it. They will ridicule me. Can I please come to this retreat?" And of course, I said yes, and he came. And he cried most of the retreat. But there wasn't so much tears of sorrow. It was tears of joy, because he finally got around people that he could relate to and he could understand, and people that understood him. And that made all the difference. And as a matter of fact, we still talk today. That was almost 10 years ago. But but that kind of discrimination still goes on from time to time. I mean, well, not from time to time. It goes on a lot. As you know, I'm a NAC board member, and as a NAC board member, one of the things that I have learned, or one of the things that I've known through being a board member is that health care is housing, and housing is health care. You can't expect a person to get well if they have no place to get well at. And you can't expect anybody to be better or get better if they have nowhere to go at night. It's hard. Trust me, I've been there, did it. And how can public get greater involved in HIV housing and facilitate? Go to the NAC, the National AIDS Housing Coalition website, please. I implore you. Go there, become a member. Why, you might ask? Why, you might ask? Because one, NAC is one of the forerunners that goes to Congress. Nancy Bernstein and her staff, they go to Congress on a regular. They there all the time. They know who got dollars, who don't have dollars, who's supporting housing, who's not supporting housing. And when they need your voice, because that's what runs Congress, is our voice. Our voice is what tells Congress what to do. If they don't hear from us, then they think everything is hunky-dory. And that's not necessarily always true. So please go visit the website. In September, we're having a summit in New Orleans. And you were talking about John Hopkins. Forgot the guy's name again. Yeah, thank you. See, I know. He's been greatly involved in the summit. And you'll get a lot of information about research. You could go to the website. We have a policy toolkit where you can actually do a presentation. We have a PowerPoint there where you can talk. There are talking points. You have to go there. There's a wealth of information, and become a member. So when it's time for us to need people to call Congress and tell them that we need more housing, we need more funds for housing, we can count on you. At least I can, and all the people that are like me can count on you to call Congress and say, look, this is an important issue, and we need fundings to fund this issue. And the last one is, as people become, they ask me, well, what more can be done? As people are starting to live longer, what I think can be done is people can start to because people are working now, people that are HIV positive, and my idea is that maybe sometimes in the near future we can offer people that are HIV positive home ownership also. And as we get people off of HOPWA and into their own homes, that would open up some slots for people who really are trying to get to those slots. So, thanks.
Thank you, everyone, and thank you to my distinguished panelists up here. It's really been a joy to sort of hear some of your stories and some of what you're doing. And I also want to say thank you to Secretary Donovan and to David Voss and all of his HUD colleagues for having this important discussion, because it is very much needed, especially on the heels of what has been a very tumultuous summer given the debt discussions going on, certainly the debt ceiling discussions going on, and how that impacts everything we do, including providing stable housing. I also want to take a second to recognize a couple people in the audience that I think is important. One is Carolyn Massey, who is a newly found friend She and I both are part of the D.C. Mayor's Commission on HIV and AIDS. We have the distinguished pleasure of chairing the Ending the Epidemic Committee. So we want you all to help us end that epidemic. Not a lofty task, I should say. And I also want to recognize two other people in the audience. Malcolm mentioned her already, Nancy Bernstein, National AIDS Housing Coalition, for all of her hard work that she does on a daily basis to remind all of us in the HIV and AIDS world that housing really is that great leveler of many of the work that we do. And another person, Larry Bryant, who's sitting up here in front from Housing Works. Housing Works has been a voice in housing and HIV and AIDS issues as long as I've been positive, and that's about 24 years. They have been one of those groups that has reminded individuals and organizations and federal officials what is the right thing to do with people living with HIV and AIDS. And so for that, I wanted to take time to recognize those people. I also want to start the premise by saying, as I think we all have understood and I think other people have said, that stable housing is critical for public health, especially for people living with HIV and AIDS. And then, in fact, stable housing was listed both, as I think Jeff Crowley mentioned, in the National HIV and AIDS Strategy and the National Prevention Strategy. And I would go so far as to say that if a person doesn't have stable housing, all other concerns, particularly those related to treatment adherence or health care, tend to fall by the wayside. And I think Malcolm Coley put it best, that it's just very difficult if you have the opportunity to access your medications. If you don't have housing, it's going to probably impede your ability to be adherent to those medications. The National Minority AIDS Council that I joined in January, its core mission is to develop leadership within communities of color to address the challenges of HIV and AIDS. We represent a coalition of about 3,000 faith-based and community-based organizations across the country advocating and delivering HIV and AIDS services in communities of color nationwide. And for almost 25 years, we have developed leadership in these communities of color through a variety of advocacy campaigns, public policy education programs, national conferences, research programs, capacity building, technical assistance and trainings, and digital and electronic resource materials. In fact, engaging the community is one of NMAC's core goals, and I know that is part of this whole panel's discussion. We work to accomplish this by hosting the United States Conference on AIDS, which is the nation's largest AIDS-related gathering in the country. USCA brings together over 3,000 people representing all fronts of the HIV and AIDS epidemic, from case managers and physicians to public health care workers and advocates, people living with HIV and AIDS and policymakers, to build national support networks, exchange the latest information, and learn cutting-edge tools to address the challenges posed by the epidemic. We also work to engage these constituents regularly via our website and email subscription lists through a variety of community and coalition meetings, including the People of Color Coalition that we have most recently formed. Through a series of articles that we started as I came on board under the auspices of Are You Ready, we began to have a discussion with the community about are you ready with regard to the transformative nature of what's going to happen with the National HIV and AIDS Strategy as we all work to the goals of the Affordable Care Act that will take place in 2014. And through those articles, we've tried to address a lot of the issues that I think we've been discussing here today, most importantly, the issues surrounding stigma. I think one of the things that we have tried to do throughout these articles and throughout, I think, NMAC's life is really work to address the role that stigma plays and continues to play in terms of people's increased risk of infection, risk of acquiring HIV. And I think there's no better way to do an attempt to really decrease that stigma by getting people to first stand up and say, Daniel Montoya, I am a person living with HIV, and I have been for 24 years. Carolyn did it as well. And we together must begin to be able to really come forward and tell our stories. And we can only do that with the support of the community by making sure that we are doing it in a safe environment. And so that's, I think, core to what we've been trying to do in terms of some of the pieces that we've been putting out. But we've also been doing that in terms of working to just do general education about HIV. We're now 30 years into the epidemic. We have a whole new generation of people who are getting infected. We have a whole new generation of people that were not around in the 80s to witness the devastating amounts of people who were dying by the droves. And I think that, we now need to educate a public that is really maybe a little more complacent about HIV and AIDS, that think because they can take a pill that it's not an issue. And so I think that's increasingly concerning. As Jeff mentioned earlier, 30 years into the epidemic, he talked about what was going to be released today regarding the CDC HIV surveillance data. This is clearly an epidemic of gay men, men who have sex with men. And we need to really work to address that, because when you address stigma in HIV and AIDS, you also have to address stigma and what it means from homophobia and everything else in terms of trying to ensure that we are really reaching those populations. And so that is something that we continue to work on. It's also very clear that as we do our work at NMAC, that you cannot, much like you cannot inextricably unlink HIV and AIDS and housing because they are linked, you cannot unlink race and poverty and the connection that they bear to HIV infection and risk. So one of the things that we work really hard at is working to ensure that, as we've discussed today, what are those social determinants of health? And what's the role that they play in making sure that as we develop capacity building programs, provide technical assistance training, how are we taking to that account to make sure that we're redeveloping cutting edge programs for the communities that we serve? Most importantly, I think some of the work that we've been doing as of late, and I mentioned it earlier, is really working around some of the budget and the appropriations process that goes on here in Washington, D.C. We are that voice for those organizations in the rural areas of the country, in the urban areas of the country, all throughout the territories, to really bring that voice to the halls of Congress about what is important for your communities at the local level. And while in many ways in this past budget cycle, even in the President's fiscal year 12 budget that he put forward, HIV and AIDS has not faced major cuts like other disease areas have. We know that because of Congress's concerns and their ongoing negotiations with the deficit, that there will be challenges moving forward. We experienced that most recently with the push to defund Planned Parenthood and what that would have meant to people living with HIV and AIDS. And so as we move forward, one of the things that we are going to really be working really hard at is begin to demonstrate a lot of what is the cost benefit for being able to ensure that people with HIV and AIDS have access to medications. We already see by the science, as was mentioned earlier, that people who are HIV positive, if you get on treatment and you're able to reduce your viral load, the chances of you passing that virus on to someone else is minimal. And so what we need to do then is how do we take that science and that evidence and make sure that we provide the appropriate messaging for people of Congress to understand the importance of treatment and increasing access to care and linkage to care. We know that preventing all annual HIV infections, which are estimated right now at 56,000, for just 1 year would save about $20 billion in lifetime medical costs. So those are the types of messages that we're trying to really advocate on the Hill, because this has become a numbers game, and not just about the number of people living with HIV and AIDS, but what are the cost benefits of really making sure that people with HIV and AIDS have access to those medications. I think it's safe to say that in this room, we all understand the importance of housing, and we all understand the importance of people accessing care at any level. But we're in an environment where being able to do that in a way that is understood in their language is something that's very important, and that's what NMAC tries to do. So one of the most important things I think I've learned in my 22 years working in public health is that problems as big as HIV and AIDS cannot be solved by one person or one sector alone. In fact, it takes a collaboration of both public, private, and nonprofit sectors coming together, people living with HIV and AIDS being a part of that conversation, to ensure that together we will be able to achieve the goals of the National HIV and AIDS Strategy and see the full future in the implementation of the Affordable Care Act by 2014. So thank you very much.
So I've got a couple questions, and it looks like there might be some more coming in. So if you need a piece of paper, just raise a hand. But if you have a question, just raise your hand as well and pass it in. For Mr. Burden, how was AIRS able to build its interfaith community, as the name of the organization suggests?
Well, it started off with a lot of the interfaith community's support. And, probably unlike a lot of organizations, I mean, we were pretty fortunate to have a strong representation of the Jewish community, the Christian community, multiple denominations. We still continue to do that. My development director is here, and a big part of the work that she does is continuing to maintain those relationships with the various congregations and churches and synods to ensure that we continue to get the support. It's again, because the information in general about where HIV is and the fact that people don't feel the urgency that they once did, I think that it's affected the way that even those mission givings in the faith communities or the various churches work and how they ultimately translate to organizations like ours. So, I tell folks all the time, it's very much like the Susan G. Komen approach is that, the reason that they're able to be so successful in the fundraising is that they pound the message that, everybody is impacted by this and that everybody needs to get involved. And so when organizations that are doing that work are out doing the ask, they're not having to do education on top of it. So it's not easy, but, those are the ways that we're trying to go about maintaining that interfaith relationship. I will say, though, just to be honest, we turn it on and off because the federal government up until now hadn't been very open to, the interfaith would scare off an application, and so we would use our acronym. And so now it's nice to see that they understand that there is a balance between being able to bring the benefits of the faith-based community to the table without the fear of proselytizing or any of those things that I think are probably the natural thing that people are concerned about.
Okay. For Ms. Hauk, a couple questions I'll put together. I'm glad to hear about your cross-jurisdiction planning and coordination efforts. What advice do you have for smaller faith-based organizations with limited ability to attend meetings to be able to connect to the national capital area? And also related, how can we approach new state and local government and non-government organizations to expand engagement? So advice for smaller organizations to get involved and connect.
So I think it's great questions. Thank you. I think that there are a couple of different opportunities that I can speak to Maryland specific, and I don't know if this is applicable to all jurisdictions, but from a Maryland perspective, we actually work on a number of different levels to try to provide resources and training to our faith-based partners. So, for example, we have a program that we run jointly with the Institute of Human Virology that's a training calendar. And within that training calendar, we have a number of different grant writing programs that are geared to all faith-based communities, faith-based organizations, as well as CBOs, to really help build the tools and the skills to be successful in applying for federal funds or even some of the state-level funds that we're able to put out into the community. I think the other thing that we do is we actually have a training program that's specific to faith-based communities. So we've worked over the past few years to put together about 16 different workshops that are available to the Jewish community, the Christian community, and the Muslim community that really use the tenets of those faith communities to frame how do you talk about HIV generally or with specific populations. And we can use that as a tool to build capacity within the faith-based organizations or in faith communities to again think about their role in education and outreach around HIV. I think the challenge, and I think Carolyn speaks to this very well, as do others in the state. I think the challenge is, and FT just mentioned it as well. The challenge is really articulating the space of and the role of faith-based HIV and being successful in applying for funding in order to be able to implement what that mission and what that role is. And I think that's an ongoing challenge and an ongoing area of work where working in partnership with our federal partners at the Office of Faith-Based and Neighborhood Initiatives at all of the federal agencies, as well as the state level and the faith communities, is really, I think, an area where there's more opportunity and more room for partnership and growth.
This is written for Mr. Montoya and Ms. Hauk, but I'll open it up in general. Are there special emphasis on educating school-age youth about HIV and AIDS in ways that are acceptable to parents and school curriculums, community boards, and community acceptance? If so, how? And can you point them towards some of that?
We don't necessarily do some of our education based at school-age children. What I would encourage people to do is to look at some of the work that's being done at the Division of Adolescent School Health that has now been, I think, more integrated with the HIV and AIDS work at the National Center at CDC. And I think that would really give you an opportunity to understand what they're trying to do. We would be working with the people that would be influencing those potentially school children in the sense that we'd be working with those parents to try and make sure that they understand the importance of children getting the type of education that they really need. So that would be more our role. And while we try to do that in every fashion in terms of when we do our capacity building and training programs, you know, that's an effort that really needs, I think, some focus. And so would welcome the opportunity to work with others on that.
From a state health department's perspective, I think it's important to understand the roles within each jurisdiction of your state Department of Education and your health department, as well as the dynamics at the local level, which involve the superintendents, the school boards, and the PTA. So I think I can speak for Maryland. We certainly do work in partnership with our Maryland State Department of Education. There are standards in the regulations for offering comprehensive sexual health education in the various grades or throughout the various grades. And there are guidelines and standards for what those curricula need to include. I think the challenge is, again, each local jurisdiction has its own ability to determine when that happens and what curricula are used. And I think that some of the local dynamics drive that conversation more than the state level or even the national level dynamics around the importance of offering comprehensive sexual health education. So I think if folks are interested in influencing that, that very much is a local level decision-making process, and one that I would encourage folks who can be involved in their school boards or their PTAs is making sure that there's enough information out there about appropriate comprehensive sexual health curricula that can be used in the school systems.
And I think we're about out of time. Is that correct? 5 minutes? Okay, I've got about 7 questions in 5 minutes, so I'm gonna ask one because it's addressed to everybody on the panel. So with the International AIDS Conference coming to DC next summer, what are your organizations doing to support increased advocacy to fully implement housing as a core element of city and state level comprehensive HIV and AIDS strategies? Big question, but really in the planning processes that you all are involved in a variety of levels, what kind of role does housing play, not just in the discussion, but at the concrete planning?
I can tell you that from our end, the National Minority AIDS Council, that we're not approaching this sort of in a silo effect. We have been meeting with a lot of our national partners, and most recently met a month ago to talk about sort of, you know, making sure what we were going to be doing for the International AIDS Conference. I think it's safe to say, as I stated earlier, that, you know, the great leveler of everything that we do is housing. So it's hard for us to extricate housing from anything that we do, because that's the basis for reducing HIV infections, increasing access to care, minimizing health disparities. And so I think from our standpoint, what we are going to be doing, and I would encourage others to do, is to really go to that website and figure out how you can get involved. I know that there was things being pushed out even most recently about getting involved with the Global Village and things of that nature. But it's a very structured process, because a conference of that size, remember there's 25,000 participants, I think it's one of the largest in the world, you know, in order to put on, it needs some sort of structure. And so there are various roles that the community plays in some of what they call their CCC, their community coordinating, and I forget what the last C stands for. But, in that, we have people with HIV and AIDS, representing different portions of that. And again, I would imagine that housing is a big factor of that. It's not just an issue in this country, it's an issue in many other low to middle income countries as well. And so I'm sure you'll start to see that play out as well.
So from a state health department perspective, I'll focus my remarks less about the international conference because I think Daniel certainly covered that. The conversation around housing happens at all of the various planning groups and all of the various conversations we have internally at the state health department level around prioritizing housing and resources for housing, whether that is through our Ryan White funds, because certainly our Ryan White funds include support for housing, whether that's through our emergency financial assistance or through other supportive housing that the Planning Council allocates resources for, as well as working with our HOPWA funds that are available in our jurisdiction to make sure that the housing needs of people living with HIV are addressed. And certainly there's an acknowledgement and a conversation in our HIV prevention funding around the important role of housing as well. I think the challenge, and I think this was articulated in previous panels, is that there are dwindling resources for housing, and so even within prioritization processes, it's challenging to find those resources that are needed, as well as, quite frankly, affordable, decent housing for individuals. And so I think we continue to prioritize at the state and local level the importance of housing and the role of housing in HIV, but really bump up against some significant barriers in being able to achieve stable housing for all of the people who need housing among people living with HIV. But it's I think an ongoing effort, and one that, again, folks have already spoken to the need for collaboration and the need for coordinating those efforts across all levels of not only government but community.
I don't think I could really add more to what both of my colleagues have said. For us, one of the things that we really focus on and try and seize every opportunity, whether it's an international conference or a local opportunity to raise awareness about the issue, we have tended to most recently just kind of make more of our focus about the need for affordable housing in general, because I think we've heard, through various members on the panel that housing in itself is really, the lack of it in general has been the issue. We have housing that's connected to very specific services, and for a number of our clients who are adhering to it, they really don't need the services anymore, but they can't leave because there's no place for them to go. And so our focus stopped being on, I've got to build that housing that's so specific to HIV disease, and I just need to build housing that people can afford to live in and manage their lives and take their medications and be able to move forward, independently.
Go to the National AIDS Housing Coalition website.
Are you paying him?
And
what a wonderful
with
board
that,
member.
Correct me if I'm wrong, I think it's nationalaidshousing.org. Nancy? Yep, www.nationalaidshousing.org, if you're not familiar with it. As with the previous panel, there are a number of additional questions, Mr. Bird, and there were a few specifically about your services. So if folks with those questions, if you want to perhaps approach afterwards and could ask the specific questions as well as I had two more for your research as well. So feel free to come up and speak with our panelists afterwards. I'd like to thank my fellow panelists very much for participating, and I think there'll be some wrap-up. I'll just really take a moment for my own wrap-up of the session, and I think that one of the comments I heard actually in the first one, in the wrap-up to that, sticks with me, that there's really been the strong public health perspective presented here today. So that even as much as the topic about outreach and engagement with faith-based communities really, I think, highlights the public health element of that and the importance of that outreach. And we've kind of heard it from all sides of that issue, from people living with HIV, the importance of speaking, the importance of providers, as with FAME earlier, who responded to how do they deal with kind of overcoming perhaps their own institutional barriers to serving people with HIV/AIDS. They said they just did the right thing, so clearly they were listening to the planning councils that are run by states and communities, and the imperative to listen, and then, of course, really overall effective response. And I've heard a lot in both panels really emphasizing evidence-based responses, which is very encouraging to hear. So with that, I'll thank my panelists, and we'll be wrapping up. And thank you all.
Yes, give yourselves a hand as well as this panel. This has been a great day. It's been a great day. So that we can continue all this work, and just a little housekeeping here, please, whatever you do, don't forget to fill out your evaluation sheet so that everyone will understand the importance of having meetings dealing with this subject, and we can do more and more and continue to make sure that this is good. I just want to say a special thanks to the White House leaders, Ms. Alexia Kelly and Mr. Crawley, the HHS speaker, Dr. Harrison, and the moderators, Dr. Sidnor and Dr. Sherwood, all of our fantastic panelists, all of the panelists. Thank you so much. Also, please recognize our dynamic Linda Ayala for her coordination, the brilliance of Travis Emery. Travis, please stand up. Okay, J.C. Shea from the Baltimore office, and David Voss, if you're still here, thank you so much. Mrs. Carol Payne, thank you. And I would like to say Paula Lincoln and the staff of the Center for Faith-Based and Neighborhood Partnerships and the HOPWA offices, we hope this event has given you the opportunity to learn more on the issues and given you an opportunity to know that you connect your community and network with each other and building and linking resources. So I always close every program by just saying, you are the willing, led by the unknowing, doing the impossible for the ungrateful. You have done so much with so little for so long. You are now prepared to do anything with nothing. Thank you again, and have a great evening.